Good afternoon. So I'm going to talk about repeat trab. So the question comes, why do we need another surgery? And before we decide a new surgery, we need to know why did the first surgery fail? So we look at the diagnosis, we look at the disease staging, the techniques and the antifibrotics which were used, what was the skill and experience of the surgeon, how long did that trabeculectomy survive? What is the age of the patient, the comorbidities, and the availability and accessibility of caregivers? So if we look at the careful consideration of the various factors, we've talked about the patient factors, but what is very important is the patient's willingness for surgery. And then when we are planning a surgery, let's say a trab, we need to see what is the site for the repeat trab or tube, as my opponent would talk about. So we look for scarring and inflammation, encapsulation, cyst formation, vascularization, patency of the earlier sclerostomy, and the mobility of the conjunctiva. Much of our wisdom is drawn from the TVT study, and I'm sure my opponent is going to bring about and say that the failure in the trab group is much more than the tube group. But that comes with the understanding and the interpretation of the study. So the interpretation which was given does say that there is a higher success rate, but it also says that there is a similar IOP reduction and similar AGM use. It does talk about the complications in both the groups, and there is no incidence of vision loss which was different. But what we need to understand is the misinterpretation of this study. So the failure rates of trabeculectomy were higher, but they were not more than what was seen in other studies. So the tube had a better failure rate because of the selection of the patients which was there, and they had a less propensity to fail. Even the authors have commented that the TVT study does not demonstrate clear superiority of one glaucoma operation over the other, and the results need to be discussed. And what we need to understand is that the complications definitely statistically put, you would see higher numbers in the trabeculectomy, but the seriousness of the complications were more in the tube group. So you had more, 2 times more persistent corneal edema. The tube shunt, if requires to be removed in cases of tube erosion, it has to be removed. Persistent diplopia was more, CME was more, and the more frequently, though not statistically significant, reoperations. Trabeculectomy group had its own share of complications. So therefore, why Re-trab? So my take is because there is a greater likelihood of achieving very low IOPs without medication. If we have a younger patient and we perform a trabeculectomy, we buy some years and we keep other options like a tube in our pocket to be used later if needed. If the tube surgery fails, you're pretty much at no other option but to go in for another tube. We can titrate the trabeculectomy, and in tubes, you have to, if you're using a non-valve one, you have to wait till the valve starts functioning. And trabeculectomy becomes difficult if tube is there. So we will only have to have another tube or cycloablation. And let us not forget in our context the cost. So we have statistical analysis of lots of things, but what matters is the patient sitting in front of us, and what matters is our skill. So the result in your hands are what would matter, and not what the others are doing. So your familiarity, and therefore we know that in our country, the familiarity with trab is much higher than a tube. And of course, we need to take into patients' wishes and willingness. And we must remember the follow-up visits. We live in difficult times. So your choice of tube or trab may ultimately come down to safety, and my choice remains Re-trab. So over to